We are waiting on Marcus. Is Marcus joining us?
I think he is. We've had sort of a CAO office training thing going on, so I'm guessing he's trying to get his fanny. I had to leave there, go to another colleague's house here in Watsonville because the Wi-Fi was so terrible where we are. So I'm sure he's just trying to get himself settled. I know he absolutely is planning to be here.
Okay. So should we wait or should we start?
Well, that's up to you. Is John not joining us tonight?
I am here. I
hey,
hope you can hear me.
Hi.
Hola from Cabo San Lucas.
Oh, nice.
Muy hermosa.
I guess I would say with
yeah.
4 of 5, I mean, we probably can go ahead and Marcus will join.
He just jumped on.
Oh, good.
Okay, so I'm going to do the best that I can today. I got a little COVID exposure, so I'm crossing my fingers, but I have a little bit of a headache. But so should we go ahead and open it up and officially start the meeting?
Let's do it.
Okay, so it is 5:01. Welcome, everybody. We will start our Baja Valley Healthcare District meeting, the first prior to the hospital. So, Erwin, do you want to take roll call?
Yes, Jasmine, I'm going to let Alejandra clerk the meeting here. I'm here for support. And also I want to make the announcement that the hospital district meeting will be following immediately this meeting. And go ahead, Alejandra.
Okay, Gabriel Cox.
Here.
Nájera.
Here.
Núñez.
Here.
Pimentel. Pimentel.
Here.
And Friel.
Here.
We have quorum.
All right, so we're officially calling this meeting to order. Welcome, everybody, and welcome to our guests. At this time, are there any late additions to the agenda?
No, Chair, there are no late additions to the agenda from staff's perspective.
Okay, thank you. Then let's open it up to public comment.
Sure, and I'm going to go ahead and read the statement for public comment. Now is the time for public comment. If you wish to comment, please find the hand icon on the bottom of your screen and click on the icon to raise your hand. I'll call you by name when it is your turn to speak. We ask that you please state your name at the beginning of your comment. Once you begin speaking, the timer will start. The countdown timer will display on screen. If you are calling in by phone, please dial *9 now to join the speaker queue. This will virtually raise your hand. I will identify you by the last 4 digits of your phone number. Please dial *6 to unmute yourself and begin to speak. At the end of your 2 minutes, your microphone will be muted automatically. Ahora es el tiempo que la Junta de Directores recibirá comentarios del público. Si gustaría dar su comentario en español, tenemos servicio de traducción disponible para asistir. Si desea comentar, busque el icono de la mano en el fondo de la pantalla y haga clic para levantar la mano. Esto lo colocará en la fila para hablar. Cuando sea su turno de hablar, le llamaré por su nombre y verá una ventana emergente en su pantalla preguntándole si quiere activar su micrófono. Por favor, acepte y comience a hablar. Si se ha unido a través del teléfono, por favor marque *9 para levantar la mano y estar colocado en la fila para hablar. Cuando sea su turno, le llamaré por los últimos 4 dígitos de su número de teléfono. Por favor, marque *6 para activar su micrófono. Al final de sus 2 minutos, su micrófono será desactivado automáticamente.
All right. Is there anybody in our public wanting to make a comment?
I don't see anyone at this time, Chair.
Okay, thank you, Alejandra. Okay, so we're going to move on to action on the consent agenda items 8 through 12. So just for clarity, should I go ahead and read through each of these items and then we move to take a vote, right?
No, it's not necessary to read through each of the items. You would just at this point ask whether or not the board members have any need to discuss or have any questions.
Thank you, Jason. Board members, is there any need for any discussion on any of the consent agenda items 8 through 12. Okay, can I get a motion?
Just a comment of my apologies. I was just commenting on the appreciation of the updates on item 9 for the fundraising update. We've made incredible progress and I appreciate the updates. Otherwise, I'll move for approval of the consent.
I'll second that. This is John.
Public comment first.
Oh, they just took public comment.
On general, they don't
yeah,
need to do it on,
yes,
okay,
they-
I'm
they
sorry
don't need
about
to do
that.
it again.
That's okay. All right, so there was a motion to approve. I believe that was Marcus. And there was a second by John. Do you want to take a vote? Alejandra, do we need to do the vote?
Yes, Chair. Gabriel Cox,
Aye.
Nájera,
Aye.
Nunez,
Aye.
Pimentel,
Aye.
and Frio.
Aye.
The motion carries.
Excellent. Thank you so much. So the consent agenda item has been approved. And now we're going to move on to report back of any ad hoc subcommittees of the board if necessary. So would anybody like to provide some updates on any of those ad hoc subcommittee meetings?
If Aldo would allow me to right now, I do want to just kind of read through the presentation that was added onto our consent agenda as a brief update for the public about where we're at with the fundraising efforts. We're getting closer and closer every single day. I just want to highlight a couple of big pledge commitments that we got over the last couple of weeks, including one of $950,000 from Roland and Pat Reveley. Traditionally, they do a lot of their giving in Santa Cruz, but they realize how big of a issue this is countywide and how big a loss this would be for an entire community. And so I want to give them just an incredible amount of credit for making that commitment to us over the next 3 years. Also, the Bros family, they've given a $100,000 commitment over the next few years as well too to help us get there. Bay Federal Credit Union, $30,000 recently, another pledge. Amy Newell pledged another $5,000 and donated $5,000. And also Rocky and Judy Franich, they have not only been a huge partner in this with us in terms of connecting us with several folks throughout the Pajaro Valley and throughout the Santa Cruz County, but they've also decided to pledge $50,000 to our cause. And so just everyone that we've named there and all the people that have donated to us over the last 3 months or 4 months, however long it's been, just thank you to every single one of you. It's not over, you know, but we're getting closer and closer every single day. And I think it was in late May, if not early May, when I said the next couple of months, I feel like we're really going to be hitting our stride in getting donations coming in and really getting the community to buy into us as an investment. And I really truly believe that at the time, and now we're starting to see that come to fruition. So everyone, whether you're on a call now or maybe watching this, you know, back later or reading it, maybe a recap in some local publication, wherever it might be, just thank you for everything that you've done for this this effort.
Thank you, Tony. We appreciate your efforts as well. We know that you've been working really hard on the fundraising and you've been just doing an excellent job. Marcus, I feel like you have something to say.
Yeah, the ad hoc on the transition has always got a lot going on. As John can attest to, there's 7 or 8 different phases of preparing to receive the hospital and transfer ownership from the current owner to this district and then to the hospital corporation for management. From as small as we're on week 5 of opening bank accounts, which is hard to imagine, but the coordination it takes to set up new bank accounts in a timeline so that ADP can be ready to go for payroll September 1st. That's just an example of the little details that are taking so much effort. And then there's the big details of working with our managed care contract providers and negotiating increased rates to sustain our hospital in the long term. We know we have a sustainable plan. We know we have the funding now to get us close to acquisition and give us some opportunities for success we're so close on both fronts that now it's just working on the details to make sure they play out. The transition team, there's right now 1 to 5 meetings a week, depending on the topic. But I just appreciate all the work that so many of the staff on this call and the staff who aren't here and the support and the consultants, even the sellers team are all working collaboratively to make this a success.
Thank you, Marcus. Katie, I know we didn't have a meeting last week for clinical. Do you want to provide an update from the last meeting?
Sure. We are going to meet as a whole group tomorrow. And I think, just from a big overview standpoint, it's been so important and really, I think speaks to the collaborative process to have a table where the current executive team and the clinicians and the project can all meet together to share these updates and really receive input and give a forum for input for people on the ground, namely the physicians that are, really looking forward to being on the other side of this transition and all the good work that is in our future. So we have another meeting tomorrow to start discussing more guiding principles around how to make decisions for service lines. And so just more good things to come.
Excellent. Thank you, Katie. Anybody else on the board have any other additions or any subcommittees? I've been sitting on the communications one. I was not there this week. I was out of town, but that is constantly, I feel like our communications team works on trying to figure out how to respond to requests from media and really be able to express ourselves as clearly and directly as possible. So that's an ongoing meeting. And I think that also I'd just like to acknowledge that Kayla Kumar, she's been on our fundraising committee, is going to be leaving us and has accepted a new position with the Diversity Center. And I just want to say how thankful we are for all of her help and wish her the best of luck. Part of those many people in the backgrounds doing a lot of work for us. So we really appreciate that.
Hey, Jasmine, this is John. I just wanted to compliment you on the statement you made to the Santa Cruz, what is it, electronic newsletter, I guess, that came out yesterday or the day before. Very positive in the progress that we're making with our fundraising. And I thought it put a nice angle to the hard work that everyone's doing. So I just wanted to congratulate you for saying it the way you did versus, oh, we've got so much more to do and so forth. You made it very positive, which I think is helpful as we get close to our finish point. So
yes, thank you.
Good job.
That reporter in particular was very optimistic and positive as well, and really saw what we're doing and what we're trying to do. But you never know.
That's right. Well, sometimes you can tell them something and they print just the opposite. So you did a good job of convincing or using the right words in a positive way. So hats off to you.
Thanks, y'all. Okay, so why don't we move on to our regular agenda? And the first item on our regular agenda is a presentation on the 1206B clinics. It's an informational item only. So who's going to be walking us through that? All right, Noelle.
That'd be me. So I have some slides. So let's hope that I can figure out how to share my screen. Can you see that?
Yes. No
Yay! They don't teach you this stuff in law school. All right, so management staff thought it would be really helpful, and I know Director Pimentel had asked at a prior meeting, what the heck are 1206B clinics, and why are we talking about them? How do they fit into the overall picture of what is trying to be accomplished here? So we wanted to do just a short little session to explain that, not overwhelm with too much detail, but give some kind of big picture concepts so that when you talk about this in the community, you'll understand and be able to explain it. So let me see. Oh, there we go. Okay. So the primary purpose of having a 1206B is to
make sure that the community is getting what they need. And as you all know, what you need isn't necessarily always a general acute care hospital, right? You might need primary care services. You might need physician office services. You might need other things that you're not necessarily going to get within the four walls of the hospital. But being a district, it's important that the district try to help ensure that those types of services are available in the community. We find that many times physicians in the community are leaving. They want to go work for a Kaiser where they can just practice. Dr. Gabriel Cox might have some sympathy in terms of when you become a doctor, you just want to be a doctor. You want to practice medicine and you don't want to have to fill out forms and call payers and hire staff and manage and all that. You just want to be able to practice medicine. And so a 1206B model allows physicians to do that. In some communities, there's a move by physicians to move to what's called concierge or cash-based models. I'm sure you've heard about that. The result of which is it further limits care in the community to the majority of people in the community. The final bullet point that I mentioned is that doctors just want to practice medicine. That's why they went to law school. So what are ways that that type of environment can be supported to allow the community to get the services that it needs and to attract the physicians to the community so that they can provide those services? So there's a few types of models. One is what's called a 1206D clinic, and those are commonly your rural healthcare clinics. They're attached to the hospital, and they're part of the hospital licensure. We've got community clinics like Salud. Salud's a community clinic. It's set forth under Health and Safety Code 1204. Then we have medical foundations. The Palo Alto Medical Foundation is probably one of the biggest ones and one of the first ones. It requires that the foundation have a certain amount of specialties and a certain amount of doctors. Sometimes it's hard to meet those requirements. So they're not as common. We've got MSO arrangements. I think one of the big provider groups in the community is this Coastal Health Partners. They have an MSO arrangement under which management services are provided to the physician's practice to allow them just to practice and not have to worry about all the administrative stuff that goes along with that. We've got what's called a friendly physician group, a friendly PC model, in which there's alignment between the professional corporation that employs the doctors and perhaps the hospital. And then we have the 1206B, which is a very unique, narrow concept that the district as a public agency is allowed to take advantage of. So what exactly is a 1206B? So there's a code section under the Health and Safety Code that says that any primary care clinics that are conducted, maintained, or operated by the state of California or by any of its political subdivisions, which would include the district or districts, can operate what's called a 1206B as a primary care clinic. And when you or the public think of primary care clinic, you might just think of your general practitioner, the doctor that you go to if you have a cold or a flu or something like that. But they're not necessarily that limited. It could be orthopedics, it could be cardiology, it could be OBGYN. It's pretty broad. There are some specialties or services that can't be included, like a surgery center, a dialysis center. But as a general rule, you could think of this much like a physician's office. You go see your cardiologist, you go see your GI doctor, you go see your dermatologist. Those could all be under the umbrella of a 1206B clinic. They are not operated under the hospital's general acute care license, which is why this presentation is in the district agenda and not the nonprofit hospital agenda. It's entirely separate from the nonprofit hospital. And it's only available to public agencies and districts. So a simple nonprofit, the nonprofit hospital, cannot operate the 1206B. So what are some of the advantages? The biggest one, and you will probably all appreciate this, is it's exempt from licensure. So all the licensing work that's being done right now on behalf of the nonprofit would not have to be done for the 1206B because it operates much like a physician practice. It's exempt from OSHPD, and OSHPD is the agency that oversees the four walls of the hospital, making sure everything is safe, earthquake compliant, the spaces are proper, and it's usually very costly to be OSHPD compliant, and it makes things take a lot longer than maybe you'd like. The 1206B clinics don't have to be OSHPD compliant. They're easy to set up. They're done by a board resolution by the district board. There's no Joint Commission survey. Some of you have probably heard about Joint Commission, the agency that comes in and makes sure that quality in the hospitals is appropriate and lives up to a certain standard. Joint Commission is not does not oversee the 1206Bs. And it gives physicians the ability to just practice medicine with little or no administrative tasks. So it does have some disadvantages. Enrollment into the government plans like Medi-Cal can sometimes take a little bit of time. The structure is sometimes confusing to CDPH because they think they're supposed to be licensed. So the individuals who are working in the clinic need to be really clear of the structure so that they don't perpetuate that confusion. If CDPH does come in and ask for the license, they need to understand why they don't have a license and why that's proper. They're not provider-based, and provider-based is a outpatient setting that's usually attached to a hospital license. They are not provider-based, so they don't need to go through that provider-based process. They do have to be enrolled in Medicare because they'll do their own billing. Again, it would be separate and distinct from the hospital nonprofit. And they have to figure out how they're going to support any losses or deficits that the 1206B encounters. Sometimes a large part of the population that's served by the 1206Bs are, for example, Medi-Cal, where the reimbursement rates are fairly low. So the overhead may not be covered by what's coming in the door in terms of reimbursement. And so some mechanism in order to support that loss. So this is what the structure looks like. I'm a visual person, so it always helps me to pencil out how it looks. And so in the middle there would be the district that would operate the 1206B, and it has responsibility for doing things like space, billing and collection. It would contract with Medicare and Medi-Cal for payer services. Also, other private payers, Aetna, Blue Cross, things like that. It would have the EHR that's needed for that clinic. It would provide all the non-physician personnel. So MAs, RNs, assistants, billing folks, anybody that's needed in order to keep the practice running. And then the district would contract with the medical group for the professional services that are provided in the clinic. The district cannot, under the corporate practice of medicine, and we touched on this really briefly at one of my original presentations, can't just simply employ the doctors. It would be super nice to be able to do that, but it's not really possible. So the district contracts with the medical group, and then the medical group contracts with the individual physicians, either as employees or independent contractors. So that's how that workflow happens. So the money comes in to the district, it goes out for the overhead, and then it goes out to the medical group to pay the doctors to provide the services. So that's a very, very quick basic understanding of what that structure looks like.
Thank you, Noelle.
Any
Are there
questions?
Yes. Any of the board members have any questions for Noelle?
So Noelle, this is John. Quick question. It sounds from what you said in the summary you gave, this particular model for us, not saying we need to do it now, but in the future, would be a good one if we needed to recruit physicians to the community.
Absolutely, absolutely. It's to help ensure that those physician specialties that are needed in the community are in the community. And you have some tools as a healthcare district to be able to do that. And then you have a place to put those doctors.
Thank you.
Cecilia, you have your hand raised. Go ahead.
Yeah, I wanted to expand on Noelle's response. There is an existing medical group that is associated with the hospital today. And remember, Noelle showed you all the different models, that the model that they have is this MSO, a management services organization. And that was in the bankruptcy, that is a bankrupt entity today. So their MSO is a subject, just like the hospital is the subject. And so we are going to need to figure out how to, because we need the doctors in the community and they have not been practicing on their own, if you will. They've had all this support. And so I think Noelle is beginning to educate you about this, is because this is likely the optimal way to address the medical group that is already in place there at the hospital.
Thank you, Cecilia. Marcus, you had your hand up.
Yeah, less of a question, more of a comment. I really appreciate this overview. I think part of one of the many motivations is, of course, learning and making sure we understand what is coming and why. But I stand reminded of how creative and how passionate everybody is to come up with a solution. Very much like a couple months ago when it was determined that should we form a hospital nonprofit to go along with this district board, we would be saving this community, keeping in this community over $10 million a year towards a hospital. This is another creative solution to having a service live within the district to give us the opportunity to keep physicians here focused on providing services instead of administrative duties. So I'm thankful for the presentation, but I'm really grateful for, again, just everybody's teamwork on finding creative solutions to maximize our services and sustainability to deliver services to our patients. I know that's a lot of words, but I'm grateful that we have this team who are coming up with solutions.
Thank you, Marcus. Tony.
Thank you. Yeah, Noelle, I think you started off the presentation by saying that this is kind of the model that other for-profit hospitals use, like Sutter and Dominican, I believe. Or did I misunderstand that, Noelle? Or is that
So they likely use the 1206 EL model, in which it's not as close of an alignment that as the B would be, but it's a common vehicle. The downside is it requires, I think it's like 50 doctors and 20 different specialties or something. It's a really hard standard to meet in a small community to be able to do the L. Mm-hmm.
Okay. Do our neighbors over with Salinas Valley Medical or CHOMP or any of those other similar sort of hospitals that we're trying to stand up here, do they use this sort of model, or what model do they use?
So I think they have some Bs and some Ds. Ds would be attached to their hospital. One of the probably most successful clients that we have that use this model is Marin. They had a very large B structure. It's now been, they now partner with UCSF. So UCSF has come in and provides some of the administrative support for those clinics. But they had a very robust B program, probably maybe 100 doctors.
Wow. Okay.
Mhm.
Okay. Thank you so much. Appreciate it.
All right, any other, Tiffany?
I actually just wanted to clarify that Dominican and Sutter they're private hospitals, but they're nonprofit. They're not for profit.
Thank you, Tiffany. All right, any other questions for Noelle?
Okay, so I'm gonna take this off my screen. Let's make sure I did that. Oh, I did it. Woo.
Awesome. Thanks, Noelle.
Sure.
Okay, so moving on, are there board members and staff announcements? and
Chair,
reports?
I would just like to, sorry to interrupt. I would just like to point out, you do have a participant raising their hand. Do you wish to entertain that?
Yes.
Okay, if you will just give me one moment so I can put up my timer. It actually looks like you have two. So Joe, once you see the timer on the screen begin, you may unmute and please begin speaking. If you just give me one moment here. And can you all see my timer?
Yes.
Okay, you may go ahead and begin speaking, Joe.
Yeah, thank you. This is Joe Gallagher. Noelle, I think my question was partially answered, that this is really a placeholder for future needs. But I'd like to point out there are still some primary care docs in the community. And so I would hope this is done in collaboration with them, because recruiting new docs into these entities could very well drive them out of town. So retention is as important or more important than recruitment. And it's a little bit of a tricky dance. So that's my comment.
Thank you, Joe.
Let me stop the share here so I can see who else. I'm not sure if I'm pronouncing this correctly. If not, please do correct me. Summer Sharma, once you see the timer, please unmute and begin speaking. Go ahead, Summer.
Summer, you're still muted if you're trying to speak.
Samir's our
Hey, guys.
hospital CFO. Yep.
Hey.
Yeah, hey guys, this is Samir. That must have been a mistake. Please continue.
Thank you, and so sorry for pronouncing your name wrong. It's Sumer. Thank you.
That's okay. Thank you.
And
Okay.
I see no one else wishing. Oh, I'm sorry. We do have one more. Carmen Powell, again, once you see the timer, please unmute and begin speaking.
Hi, this is Carmen Powell. I'm a pediatrician here at Watsonville. I did have a question about how this designation would factor into loan repayment, particularly if you're receiving the Cal Health grants or other forms of loan repayment that are specific for either nonprofits or other community hospital entities, because that's a big recruitment and also retention tool for physicians to practice in areas like this.
Well, do you have a comment on that?
So I don't know. I haven't looked at that lately. I understand what you're saying, but I don't have an answer to that.
So that might be something that we would want to look at, in our process too, because I know for me, when I was getting my loans repaid, it was really important to work for an entity that was able to support that. So if we can look into that, that would be great.
Sure. There are recruitment options for new physicians, bringing them into the community, regardless of whether you're a public agency or a nonprofit. But I'm not sure for the Cal loans option what's there.
Dr. Powell, we'll keep that on our list of questions to add. Thank you for asking. Okay, are there anybody else in our public that would like to speak?
Not at this time, Chair.
Okay, thank you, Alejandra. So with that, I believe that we are coming to the end of the district meeting.
One more item.
Yes.
Number 7.
Oh, the additions. The board member and staff announcements and request to place additional items on future agenda. Anybody? Fellow board members, directors?
I don't know if this is the right board meeting. Funny enough, kind of funny to say that, but or if it's the hospital one, but I know a couple weeks or maybe a couple months back, Director Gabriel Cox asked if we could come up with a strategic plan, or if we could at least start the beginning to think about how we're going to form the strategic plan for when we take over and complete the purchase. And so I don't know, Director Gabriel Cox, Katie, if you'd like to kind of expound on that. I do remember you bring that up and thinking that is something we should definitely work on.
I believe it's in the next meeting. Am I incorrect?
I think it is in the next meeting, and I would say it's in the very, very early stages. And I think the overall goal is to have a real general framework so that when we come together in September, we have a place to start together.
So more to come on that. Okay, anybody else or anything else? All right, do I need to get a motion to close, or we just close our meeting? Okay, so
You
we
can
are,
just end it.
all right, so we are ending this section of our meeting at 5:36. And then let's jump in and we will officially call to order our Pajaro Valley Healthcare District Hospital meeting.
Chair, I think I'm sorry to interrupt you. I think that the clerk needs a second to stop the recording of the district meeting and then open the next meeting. I don't want to step on that though. Is that correct, Alejandra?
So the recording continues. There's no need to pause or anything like that.
Okay, great. Thanks.
Okay. All right, so let's go ahead and call to order our meeting at 5:36 p.m. Do we need to take roll call again?
Yes, Chair.
Go ahead.
Gabriel Cox.
Here.
Nájera.
Here.
Núñez.
Here.
Pimentel.
Here.
And Friel.
Here.
We have quorum.
So much. Are there any considerations of late additions to the agenda? No? Okay. Alejandra, you want to speak to the public comment portion?
Yes, Chair. Now is a time for public comment. If you wish to comment, please find the hand icon on the bottom of your screen and click on the icon to raise your hand. I'll call you by name when it is your turn. We ask that you please state your name at the beginning of your comment. Once you begin speaking, the timer will start. The countdown timer will display on screen. If you're calling in by phone, please dial *9 now to join the speaker queue. This will virtually raise your hand. I will identify you by the last 4 digits of your phone number. Please dial *6 to unmute yourself and begin to speak. At the end of your 2 minutes, your microphone will be muted automatically. Ahora es el tiempo que la Junta de Directores recibirá comentarios del público. Si gustaría dar su comentario en español, tenemos servicio de traducción disponible para asistir. Si desea comentar, busque el icono de la mano en el fondo de la pantalla y haga clic para levantar la mano. Esto lo colocará en la fila para hablar. Cuando sea su turno, le llamaré por su nombre y verá una ventana emergente en su pantalla preguntándole si quiere activar su micrófono. Por favor, acepte y comience a hablar. Si se ha unido a través del teléfono, por favor marque *9 para levantar la mano y estar colocado en la fila para hablar. Cuando sea su turno, le llamaré por los últimos 4 dígitos de su número de teléfono. Por favor, marque *6 para activar su micrófono. Al final de sus 2 minutos, su micrófono será desactivado automáticamente.
Thank you, Alejandra. So at this point, do we open it up for public comment? Okay.
Yes.
Is there anybody that would like to speak to, for public comment?
I see no one at this time, Chair.
Okay, thank you. All right, then we'll move on to take action on the consent agenda items 8 through 9. Is there a motion to approve the consent?
This is John. I'll make that motion.
Thank you, Director Friel.
A second.
Thank you. Alejandra, do you want to take a vote?
Yes, Chair.
Okay, thank you.
Gabriel Cox.
Aye.
Nájera.
Aye.
Núñez.
Aye.
Pimentel.
Aye.
And Friel.
Aye.
The motion carries.
Right. Thank you so much. And we'll move on to our regular agenda. So the first item on our agenda is transition update. It's an educational only item. Who's going to give us that presentation tonight?
I believe that I am.
Excellent. Welcome, Cecilia. Thank you so much.
Of
Take it away.
course. And may I share, am I able to share my screen, or does the clerk have the material?
I have the PowerPoint if you wish for me to share that, Cecilia.
That would be terrific. Thank you so much. As you can imagine, we are getting so much closer to actually taking over ownership that the level of activity is actually astounding to me. It's a lot. It's a lot, and rather than, I couldn't possibly go through line items, just want to hit a couple of things from this week that were are probably of note. So can we go to the next slide? Oh, so first update, just because you may read about it in the press next week, is on Monday, I believe it's Monday, that there's something called a confirmation hearing that will be occurring in bankruptcy court with regard to the seller. At this time, all of the objections, if there were any filed, and there were a few, to the sale needed to be resolved. And what the court does during a hearing like this is that they approve a liquidation plan on behalf of the entity that sold to us. And basically, where does the money go? And how does the estate, if you will, wind down its affairs? We don't think there'll be anything in particular in court that comes up about us, but because it is a major milestone in the transaction, it may get some public attention. So I wanted to make you aware of that. Probably one of the most exciting things going on right now is that the individual employee offer letters are being produced as we speak. They are they're multifaceted. We are, of course, as we committed to doing, offering employment to all current employees. And it turns out that that's a harder thing to get at than you would think, because we do have people that work per diem that haven't been there in a while. But the employee offer letters will also allow your corporation as the new employer to get access to the seller's personnel information in terms of their social security number, their home address, things like that. That triggers for data to move over to the buyer. And finally, in the offer letters, that we will be announcing the schedules that will be available to employees under the new ownership. But it's a very exciting time. The letters themselves have been are being circulated to the labor unions. And we have met, by the way, and actually Marcus was with us in some of these meetings. We did have, we including Marcus, we had some meetings with the labor unions, and now Allison, who is the head of HR at the hospital, is continuing that process. Just sort of as an FYI, Allison, the new head of HR, she is a labor attorney by background. She is being what they call seconded, which means that the buyer, and in this case, that's the project for our purposes, is able to have her work for the buyer and on the buyer's behalf during the last 6 weeks of this deal. And because there can be no confusion about who's working for who. But having this secondment agreement allows the person who is leading HR at the hospital be the one to guide the offer letter process. There is an issue that had come up with regard to one of the retirement plans. This also has been discussed with the union. It relates to the SEIU's cash balance plan. This plan, although we said that nothing would change, it turns out some things will have to change because we're a government entity. So the retirement plans will be reconstituted. And it turns out that one of them, a cash balance plan, is underfunded. So the legal team is working through a plan that will allow for the funding of that plan over the life of the plan, hopefully. And so that issue is being resolved, but that was a little hiccup too. We completed a cash flow forecast, and I would probably recommend agendizing that for a future meeting, because what it shows you and what you can expect is that although over the entire year, you are very close to cash neutral in this forecast, in the early weeks, particularly the first 6 to 8 weeks, there is cash flow disruption. And so that's why that working capital budget is so important. There could actually be interruption of claims payment, and certain things that we're trying to do as a buyer don't kick in right away. So we should review that forecast in more detail, but it is done, and that's the good news. We also did, per our discussion at the board meeting, issue notices to all of the insurance companies, and those discussions are quite active. So next slide. This is very difficult to read. I don't know if you can zoom a little bit, but as it was Marcus, somebody was alluding to, it was Marcus alluding to earlier, these are our functional work groups. We have one for communications, finance, HR, physician agreements, purchasing, revenue cycle, managed care, and IT. And there is actually one that we don't track on this slide for getting the licenses. By the way, getting the licenses appears to be very much on track. We have hit no red flags in the licensing process. So this will be distributed to the board. It's a very nifty snapshot of the main activities. And then what follows later in this same packet, if you could flip to the next page, or actually 2 forward, you'll see another one. Flip 2 slides, if you could. For each of the individual, and I think we talked about this last week, for each of the individual activities, in this case, revenue cycle management, there is a page that both says what happened this week, what's going to be happening next week, and also lists they're calling raid items, but these are items that could potentially be at risk or require immediate action. And so we keep track of those things. It's not a bad thing for necessarily something to be called out, because if it's not called out and it gets ignored, that would be much worse. So I think in almost all areas, you'll see things come under either risk or action needed. I was thinking I wouldn't go through the entire plan because I'll distribute it, or either can we distribute it later? I guess I defer to legal about how we get this to you. But there's a full report, unless you'd like me to go through all of them. But I'm just interested in your time and sensitivities.
Cecilia, what question are you asking?
I'm asking whether or not, to you, Jason, is that I do not believe this went out with the agenda packet. Is it permissible to post this to all the directors?
Cecilia, I think it did go out.
Oh, it did go out. Oh, wonderful.
Yeah, so you might want to just ask if there's specific questions from the board. Like you said,
thank you.
I read
there's
it
a lot
night.
there.
There's a lot here.
Yeah, there is. Thank you so much for clarifying. I appreciate that. So I'll do just that. Apparently you have these reports. You have any questions?
Cecilia, I don't have a question, obviously, that I haven't asked in our transition ad hoc meetings, but I just wanted to point out a couple of things. Naming conventions. These labels are being done from a perspective of project management, not from a perspective of something will fail for the hospital. So when something is at risk, doesn't necessarily mean it's at risk of failure. It just means it needs attention to get the process moving. It's next in line. And what I draw your attention to is, let's see, I think it's human resources on page 10. The whole category is labeled at risk. It doesn't mean we've got failure there, nor does it mean that it's really at risk. In some cases, it's just updates are needed. There's a lot going on in HR right now, and not all the updates have made it to this register. So the staff who are processing this This is a live breathing document. So I just want to put some context that don't panic. Like we need to always be aware and be concerned. But when you see the label at risk or risk, it's more from a process perspective. Cecilia, is that fair categorization?
That is absolutely true. And I appreciate your calling that out, because I think red, like I said, is good to identify these things and to call them out as being important. It does not mean that something bad is happening.
All right. Does anybody else have any other questions for Cecilia? Okay. Alejandra, is there anybody with raised hands?
Not at this time, Chair.
Okay. All right. So if there's no other questions for Cecilia, thank you for your presentation. Moving on, we are at board member and staff announcements and request to place items on a future agenda.
All right, I have one quick request on behalf of Monica Morales. Can you elevate her to a panelist, Alejandra? She had to call in and her number is ends in 9833.
Yes, I will do that right now.
Thank you.
Well, hold on.
Did she want to speak, Tiffany, or she just needs to get back in?
She needs to get back in.
Okay, all right, perfect.
You know, I actually don't believe that if she's calling in, I'm able to promote her to panelist. She
Oh,
would
okay.
need to, yeah, she would need to log in through a device.
Okay. Thanks.
Okay. So board members and staff announcements and requests to place on future agenda items. Are there any? Marcus.
This is Marcus, and I think staff are already working on this to bring updates on the transition of staff from current employer to new employer under closed session as need be. So it's a request to add that as needed closed session item for staff transitions.
Updates on staff transitions. Okay.
Yeah. And the staff are already aware of this, and I believe working on that for the next board meeting. I'm just calling attention to that. Thank you, and thanks, staff.
Anybody else?
Yeah, I do have a question about that last request, because there's very specific bases for us to go into closed session on labor negotiations, for example, or if the board is hiring somebody, but staff updates regarding transition is not something we would agendize or be able to agendize for closed session. I would want to talk through it more. Sorry.
Go ahead, Marcus.
Thank you, Jason. Let me add some context. Let me add some context to that. This is for the board to provide input and direction as needed in labor negotiations to support staff who are working with our labor unions and our physicians.
Excellent. Okay, thank you very
My
much.
apologies on being so generic. Yep.
No, that's helpful.
All right, thanks, Marcus. Thanks, Jason. If that's it, then we are going to be moving into closed session at this point. Is there anything else I need to do, or do we just end this part of the meeting and move into closed?
We just end this part of the meeting and pause to allow us to move into the closed session, and then when everything's clear, we can pick right back up.
Excellent. Okay, so thank you everybody for attending. Those who have joined our meeting, we really appreciate you logging on, and we hope that you continue to attend every other week. With that, we say goodbye to you for today. Thanks so much.